Good evening, everybody, and welcome to this session on Global Atrial Fibrillation Awareness Week. I have with me Dr. Malav Jhala from Mumbai. He's a cardiologist and specifically an electrophysiologist, and we will be talking to you about the topic of atrial fibrillation. And so we will try to uncover some basic concepts of the disease and understand some elements of how it is diagnosed and how it can be managed. So, thank you, Dr. Malav, for being on this session. And I'd like to kind of start off with this whole discussion by first asking you what is the difference between a cardiologist and an electrophysiologist?
So thank you, Dr. Alben. And so to answer your question in a plain language, it's the same difference between a plumber and an electrician. So
Okay.
we take care of the electrical circuits of the heart, and we take care of the rhythm disorders. And what we came to know when we train for electrophysiology is it is more of a clinical medicine many times than just doing a procedure. So that's maybe the main difference between a cardiologist and an electrophysiologist.
Thank you. That's very good to know. And so today our topic is about atrial fibrillation. But before we understand about atrial fibrillation, you were talking about rhythm. Can we understand a little bit more about the heart, the rate, and the rhythm? Now, what are these three concepts?
Correct. So you have, so what I explain to my patients is if you take your pulse and you say it's 70 beats or 80 beats, that's the lower chambers of the heart that you are seeing or feeling. The assumption always is that a heart has four chambers, two on top and two below. So if your pulse rate is 70 beats per minute, the assumption is all four chambers are beating at 70 beats per minute. And normally, the upper chambers will beat before, followed by the lower chambers. And this is maintained in synchrony by a set of cells, which we can call it as a normal circuit, which would be the SA node, AV node, whatever names you give them.
Okay.
Now, this is the rate, but the rhythm is one is that every beat comes at a definite interval, so it's regular,
Okay.
and the atria contract first, followed by the ventricle. So that that you are having a normal rate and a normal rhythm. Sometimes the rhythm can only be ascertained on an ECG.
Okay.
So that's why we look at an ECG and a pulse when we do an examination and further follow-ups.
Understood. So, for the benefit of the audience, can we consider the rate as the rate at which the heart is contracting, and the rhythm is the synchronization of that contraction? Okay,
Correct. Absolutely. Yeah.
great. Okay, so if the rhythm is abnormal, what is it considered? Like when you have a slow heart rate or a fast heart rate, you can kind of use certain words called tachycardia, bradycardia, and all that. So what happens when the rhythm is abnormal?
Correct. So if your rhythm is abnormal, it is important that the abnormality is originating from which chamber. Is it
Okay.
originating from the upper chambers? Then it is by and large non-lethal. But it doesn't mean that it is not going to affect your life at all. Or else, if your chambers of the lower side are behaving erratically, that's most of the times lethal and life threatening. And sometimes patients may have a problem from the lower chambers but may not be lethal. However, since 80% of your blood supply is decided by the lower chambers, any rhythm abnormality which is affecting the lower chambers, be it originating in the upper chambers, in a fast heart rate situation, is going to be a problem for the person at some point in time because we are looking at what we call series circuits You're not looking at parallel circuits. So if one component of the series is misbehaving, the entire pump or the entire series will misbehave.
Makes sense. So now moving to the rhythm component, right? Now we understand rhythm is about synchronous beating and this contraction, and the heart's function is to pump blood, right? Now, what happens when something is abnormal with the rhythm? Does it get picked up by the patient? Like, do they feel it, or does it only get picked up when they come to you or undergo an ECG? What happens in a patient who has an abnormal rhythm?
Correct. So, see, if it's most of the times the patients will have some symptoms. Typically, the patients will present with either abnormal awareness of their own beat, that is called palpitations, or sometimes that palpitations are perceived as chest pain. Many times, patients may suddenly fall down and become unconscious for a minute or two. Now, there has been a lot of I would say a lot of talk of seizures and falls and how do you really differentiate? It's not very difficult because if you have a bystander or if you have a relative who's witnessed this, typically if the patient falls unconscious while sitting or resting and immediately regains consciousness and is absolutely fine the next minute, this is a very typical cardiac syncope or heart origin syncope. So this is supposed to happen in rhythm disorders amongst other things. So typically the patients will come with almost near fainting or palpitations, or frequently they might present with tiredness, fatigue, breathlessness. So this is definitely 70 to 80% of the time, and it's maybe the reason why they come to us. Still, you will have 30% of the time the patients being claiming to be absolutely without any problem. But once the problem is diagnosed and treated, many times they may come with statements that, we were not feeling so well after this procedure, we are feeling much better. So it depends upon how you're going to perceive. And there will be 2 to 3% of patients who will be truly asymptomatic. So it's not that you don't find patients without symptoms, but I think 90% of the patients would have varying severity of these symptoms.
Understood. So, if I can just summarize what we just said is it's largely perceptive and sometimes can be dramatic, like somebody can have a syncope and fall down and somebody can be brought in, but sometimes it can be just asymptomatic, but the person might feel it and then instigate the person to come to them. And there are opportunities, sometimes situations where they will absolutely have not realized anything, a by chance finding, and then when something is done about it, they feel better after that. So that's very good to know. So, doctor, I think very importantly, people will always want to know, does this come at a particular age? Does it affect everybody? So I think there are some, those kinds. So can you throw some light on, is there some gender specificity, age specificity around this?
Correct. So typically, what we call the supraventricular tachycardias or SVTs, they were thought to be the disease of the young. So a fit young male or female with no other problems, absolutely normal, coming with so much of problems. That is very typical of SVT. And that's related to the abnormal circuits present in your heart since birth. So that is very typical of SVT. The other subset of patients with atrial fibrillation typically present midlife or old age. That's a very typical presentation. Now, how early will they present? It depends upon atrial fibrillation, depends upon the company that it keeps. So
Okay.
you are a diabetic, you have heart disease, you have valvular heart disease, or you may be absolutely normal, but you are a vigorous athlete, like a long distance runner, marathoner. It is proven that in such patients, atrial fibrillation onset is faster earlier, so mid 40s in some patients. And so, the prognosis of atrial fibrillation and response to treatment varies with the associated problems that you have. So, to make it simple, if AF is your only problem and you are otherwise a normal person, then if you treat it with a definitive means, whatever we can offer, it is likely that it's going to go away 80 to 85% of the time. And maybe 10% of the time, even if it comes back, maybe a second procedure and it's going to go, or it's become such a non-entity on medications that you don't really bother with it.
Understood. Understood.
Yeah.
So, are there any risk factors associated with with atrial fibrillation? Now, since we're talking specifically about atrial fibrillation, which is a supraventricular tachycardia or SVT, what we call it, are there any risk factors that can trigger this or can increase the risk of somebody having atrial fibrillation?
Correct. So there are two things to atrial fibrillation. One is the rhythm problem itself, and the second is the consequences that it deals on your body. So if
Okay.
you have we talk of atrial fibrillation as something called as an irregulopathy. So
Okay.
you know that the rates are fast and they are erratic. So a heart or any muscle can tolerate one of these problems when they come alone. But if you have irregular and fast rates, generally the muscles will fatigue over time. That's why patients tend to have heart failure in the long term, or when the blood remains in one chamber, it clots. So it
Okay.
throws in clots and you may develop a stroke.
Okay.
So when we are dealing with atrial fibrillation, we have to understand that the risk of atrial fibrillation is by no means different from risk of stroke or heart attacks. So diabetes, hypertension, sedentary lifestyle, overweight, and sleep apnea. These are considered to be, apart from certain reversible factors like alcohol, thyroid problems, specific seafood diet, or certain crash diets that we tend to do in today's day and age, which are not traditional. So these are the common triggers or risk factors for atrial fibrillation. And these are the ones which in your treatment are required to be managed in the background. Whether we give you a treatment or not, whether we give you any ablation or not, because they will decide whether the AF will come back or not.
Makes sense. So I think the risk factors that are involved are no different from any heart disease risk factors, but more importantly, the risk factors which are known to elevate this are similar to what can also cause you, stroke and heart diseases. But what I understand from you, sir, is that atrial fibrillation also can be a risk factor for some of these conditions, right? Like people who have atrial fibrillation can be at a risk of developing a stroke, and so that was what you were trying to kind of allude to. And
Correct.
so I think so. If you consider atrial fibrillation as a condition, right? And we were discussing this just before we started this call. Um, how common is it in India?
So I think as we were discussing, the numbers are far less than what they are actually there, because we never had a atrial fibrillation study in India, unfortunately. It was always in connection with rheumatic heart disease or maybe some operations. We have never done a population based study of AF. So, my conjecture is going to be based on the Western literature that we have. And that they state that at least close to 20% of elderly population will have atrial fibrillation of varying degrees and varying severities. So I think that's not a bad estimate to say that one-fifth of your elderly population is already moving with AF, and they may or may not know about the context of it.
Understood. Understood. Now, you mentioned a little bit about rheumatic heart disease. This is for the sake of our audience. What is its connection with atrial fibrillation?
Correct. So atrial fibrillation, if you were to break down to the basics of it, it is abnormal circuits in the small chambers of your heart because of varied amount of scarring. As you age, your hair become gray, same way the heart ages. Anything that hastens this scarring is likely to produce atrial fibrillation earlier and more severe. So rheumatic heart disease is basically an immunological problem of the heart. Simply speaking, it's like rheumatoid arthritis does to your joints, rheumatic heart disease does to your heart. And hence, you have more scarring and you have more amount of uh, AF burden and severity and resistance to treatment in a patient with rheumatic heart disease.
Okay. Okay. And now let's just move one step further, and we discussed briefly about ECGs and how an ECG along with checking the pulse. Can you throw some light on how do we screen somebody, or let's start at the basics. Somebody is having a symptom. What happens to that person when he comes to a doctor?
Correct. So, first thing is that I think atrial fibrillation per se does not need specific screening. We don't want to convey to our audience that, let's start going and getting ourselves screened for an atrial fibrillation. That may not help you most of the times. What does is that any individual starting 25 years of age should be not scared of going to a cardiologist or a physician. An annual blood examination, which consists of your sugars, lipid profile, CBC, complete hemogram, should be done as a routine because that serves as a benchmark and serves as an earliest indicator of things going wrong. Secondly, once you hit the age of 40, you may or may not undergo in consultation with your physician, maybe a CT angiogram to understand whether there are blockages in the heart which have developed. Because if they haven't, it's a good sign. And if they have, it is likely that you will be able to just manage them with changing your lifestyle and medications rather than waiting for the terminal event of a heart attack happening. So that's another important thing. It is also stressed that today we are dealing with a different demon. We are dealing with this sedentary lifestyle becoming a major problem. As you can see, you and I both are sitting right now and giving a 45-minute talk. Had this not been there, both of us would be traveling to a common destination, standing on our toes, and then delivering a lecture. If our lifestyle has changed to our convenience, so has the world's, that brings about a major problem to a lot of people whose only job is unfortunately sitting and working. So you need to have a discipline, a work-life balance, and you need to incorporate some sort of moderate exercise as a routine. And before you can venture into an exercise schedule, you get yourself evaluated so that you're sure you are not going in with some baggage around. So that's how I would, follow them up. Yes, should you develop specific symptoms of chest pain while walking, severe breathlessness while walking, palpitations which come at rest or even while exerting, these are typically the times when you would be evaluated. And typically, even in India, a basic ECG and an echo would be done. Maybe some sort of coronary imaging like CT angiogram or an angiogram may be done. In case your problem is only palpitations and we find something abnormal on the ECG, you are subjected to certain wearable devices like the Holters or the external loop recorders. We were used to the Holters which used to be tied to your body and you couldn't take a bath. Now we have smooth patch devices which connect to your phone. You can go work, come back, take a bath, do everything. And not only that, if you or your phone becomes non-responsive, the call center calls you and tells you check your patch at 2 o'clock in the night. You have a problem with the patch on, you push a button and you get the rhythm instantly. So this is something which has revolutionized rhythm management, because you can't you can't destroy something if you haven't noticed it. So every time AF patients used to come to us, we had no data. If you take an ECG, send them back. Ask them to get an ECG when they get it. By the time they reach the hospital, it would go back. That's where the wearable devices. So today my use of wearable devices is close to 80%. And the reason is this: if I have data, I can not only diagnose AF, but I can exclude it. And I can reassure the patient that look, when you had the symptoms, your heart rate was normal. So it's not related to the heart. That's also important because we have watches, we have other devices which may malfunction, but they may tend to put you in harm's way by making you feel that you are sick. And that sometimes is a major problem. So I think this is what I would do for patients whom we are suspecting a rhythm disorder. We don't have the rhythm in hand, put them on a hold or a ELR for 7 days and then decide based on that.
Thank you. I think just to summarize for everybody's benefit out here, sticking to the basics is always important. You start at an early age of going into a discipline of monitoring your health. That means being aware of what your health is talking to you about at a particular age. Let's say 40 onwards, it's good because Indians are generally known to have very early onset of heart disease. It's good to have a cardiologist consultation to understand if there is something that needs to be fixed. And if you fix it early, it can be done with certain medications. And then I think the whole idea about atrial fibrillation is that if you're at risk, or if the cardiologist identifies that you are at risk, beyond just doing a single time ECG, you have nowadays technologies which can be worn and that will continuously give information. And it's not about the technology, it's about the ability to take decisions on the patient. Whether you should act or not act is something which the continuous recording is able to provide to you, and which is why it is good that if you are at a particular age, you need to go and see the doctor, and at the same time, if the doctor is advising you to get yourself screened, it's good to choose these technologies because it gives a additional set of information for management. Now we'll just move to the last part of our talk to understand how is atrial fibrillation managed, and what is your role as an electrophysiologist, and what is happening in the current world of treatments for atrial fibrillation. So how do you manage a patient with atrial fibrillation, and
Correct.
what are the
So
treatment
I
modalities?
think I think one of the best times of the year to speak of management of atrial fibrillation, because so many good things have happened in India specifically, and we have reached a stage where we are on the brink of almost, I shall say, becoming a area of expertise in a lot of fields in AF management. So just to briefly, for the benefit of the audience, see, atrial fibrillation is the condition. We need to be sure when we are targeting atrial fibrillation, in what level or severity of the disease. At each stage of atrial fibrillation management, today we have one at least good definite one definitive option available which we can offer to the patient, and our aims are very what shall I say, clear. So I just to give you an example, I would quote like during Operation Sindoor, our goal was very clear. We have our very clear goals. We may not be able to destroy atrial fibrillation completely. What we look at two things. One, we look at lifestyle of the patient becoming normal. So if it's a lifestyle disease, if you are able to give them the lifestyle that they were at with a little burden of atrial fibrillation is fine. That's our main goal. The secondary goal is if I am able to give them a normal rhythm altogether. That's always a plus point for us. So if you have early onset atrial fibrillation, where most of the times your rhythm is normal, episodic wise your rhythm gets abnormal, and you are below, say for example, physiological age below 60. We don't talk of years of life, we talk of how healthy you are. I think this is the best time for you to give you a very definitive option. So what we do is we enter the heart not by opening up your heart, but from the vessels that go into the heart. And there are certain common sites which create this mischief, and we catch them under fluoroscopy or X-ray, and then special imaging techniques that we have, and using either radio frequency, that is heat, or using cold nitrogen in a balloon, that's called cryoablation. We silence these naughty nerves, as they are called, and we destroy them. That way we tend to isolate this problem, and 80% of the times it won't come back ever. 20% of the times it may come back, but it may become much more weakened. So this is what we can offer to patients who have what we call paroxysmal AF as the
Okay.
first line. Say if this atrial fibrillation becomes a problem you have been ignoring, or we have been stopping you from operating, or whatever way, and say it's been there now most of your week or most of your month, and few days are fine, and it's been there for a year. It's called persistent atrial fibrillation. So when you have persistent atrial fibrillation, obviously the disease has progressed a little more. And when
Hmm.
the disease has progressed a little more, till now we didn't have very definitive options. We used to offer them this radio frequency ablation. We used to offer them even a cryo balloon. But we used
Okay.
to say we are 50% effective in removing it altogether. So it used to be offered with caution. We have something which is called pulse field ablation, which works on a completely different concept. So it basically destroys the cell without destroying the house in which it stays, to put it plainly. And why
Okay.
it is important is heat and cold will make your tissue thin when we destroy. So we are destroying, doing a good job, but we are definitely eliminating some tissue from the body. Not only that, we may hurt certain nerves, certain parts of the body which are behind the heart unknowingly. So with electroporation or PFA, we are able to provide this modality with more safety, and it is supposed to work better in persistent atrial fibrillation. This is a concept, and this treatment option is available for a year and a half in the West. And now we are likely to start getting this maybe next year or in a by 27, so in 2 years time. So that's another option that we are able to offer to our patients. A lot of patients whom we used to miss, or they used to come, or we were not sure whether we can offer them RF, or we didn't have that modality. Then comes the last stage of atrial fibrillation, which is permanent atrial fibrillation. Typically these patients would have been tried and they have failed. Now, one more important thing that I want to tell is that these are the operations that I'm telling you. But what do we do when we first get the patient, whichever it is? How do we know that this patient will respond to my treatment? A simple tool that we have been doing for years now is that we get the patient, we talk to the patient, we take them in the intensive care unit with all due precautions. We do something called as a transesophageal echo. That's a endoscopy kind of a thing,
Okay.
and we look at the heart from the back, from the food pipe, so that we are sure that there are no clots already formed in the chambers of the heart. And if that is so, that it is there is no clot and everything is okay, but the atrial fibrillation is on, we give them a little bit of a little sedative, and we give them an external shock and reset the circuit. This is called an electrical cardioversion. See, this is a very good tool to have. It diagnoses that the atrial fibrillation can be treated with an external shock. So it is likely that the my therapies will work. Second, it's therapeutic because if the patient becomes normal, then patient is out of it. And some of the patients may just be cardioverted once a year who refuse things. As long as you are in normal rhythm, you are fine in atrial fibrillation. The problem is when your abnormality increases in terms of rhythm. Hence, I think most of these patients would have undergone a cardioversion before we take all these complex decisions. Say if cardioversion fails, medications fail, ablation has failed, or is not possible, very old, very frail. That's permanent atrial fibrillation. But the patient is admitted, and patient needs to go home now. And patient just needs to carry on with the day-to-day activities that he or she is doing. Then what we do is instinctively we put a pacemaker into the heart. We put two wires, one in the right side, upper chamber, lower chamber. We place it at the precise location so that we are able to kind of uh, emulate the normal conduction, imitate it completely. And then we just intentionally destroy the normal circuit that we were discussing before. That is called AV nodal ablation. So we basically make the patient dependent on the pacemaker, but the irregularity goes away completely and the atrial fibrillation is confined to the upper chambers alone. The patients many times will improve drastically, and sometimes the atrial fibrillation just goes away because
Okay.
we know that atrial fibrillation begets the problem itself. It's a vicious cycle. So we break it
Understood.
in this.
Interesting. So, just to summarize, I think the most important element is making the diagnosis and getting as much information on the atrial fibrillation. When does it start? How long does it last? All of that. That is very critical. Second part of it is there are techniques by which we can reverse the atrial fibrillation, and this is an emergency kind of a setting when somebody comes in and they are in atrial fibrillation. You do can do this, but it also gives you information that this is a treatable condition. And thirdly, there are treatment options which are already existing, which is either using heat, or like you said, radio ablation, or using cold, which is nitrogen based cold ablation. And some newer techniques which are coming into India very soon will be available, which will help. Based then the choice of this is based on various other factors about the comorbidities and what kind of lifestyle the person is having. And if it is moved to a stage where it is becoming permanent, we can even go in and put in a device, just like you put a pacemaker in persons who have low heart rate. You can put a device which will make sure that their rhythm is controlled as much as possible. So this is exciting news as far as the whole world of cardiology is concerned, because I think uh, generally people look at a cardiologist only when they have a heart attack. That's the concept people have in mind, and they sometimes don't understand that cardiologists are also doing procedures. They think if you need a procedure you have to go to a surgeon. And I'm not promoting anything between the cardiologist or the cardiac surgeon, but clearly the condition, the patient, the type of disease, the time at which it has been diagnosed clearly gives guidance on what pathway to take. And if there are blockages, you will obviously want to get it fixed, and sometimes they may have to go to a cardiac surgeon. So I think these are the elements of awareness that we want to promote during this particular global atrial fibrillation awareness week. And I think it has been a great conversation having you, Dr. Malav, to understand this
Yeah,
disease at a very basic concept, and also go all the way up to understanding the most complex and latest treatment modalities that are there. To conclude, Dr. Malav, maybe we'd like to hear from you a kind of a message that you would like to tell the public about atrial fibrillation in this week that we are celebrating as an Atrial Fibrillation Awareness Week.
So I think the only message I would like to convey is beware of the friends of atrial fibrillation. And don't be scared of atrial fibrillation because we have tools to deal with it conclusively today.
Thank you so much, and that is very important. And we wish you luck with your journey as an electrophysiologist. And I'm looking forward to more interactions such in this. And we are happy that we have people like you in India who are advancing the science as we are seeing across the world. So that means to say Indians are in safe hands, and it's good for us to keep in touch with this knowledge and be safe at all times. Thank you so much. And
Thank you.
so, Ravi, over to you in case you have some closing remarks.
Sure. Thank you so much, both of you. So,
Yeah.
on behalf of Monitra Health and everyone who has joined us this evening, I extend our heartfelt gratitude to Dr. Malav Jhala and Professor Dr. Alben Sigamani for generously sharing their time, knowledge, and expertise during today's session. Your clear explanations, practical guidance, and more importantly, the compassionate approach that you have helped demystify atrial fibrillation for a lot of people around. And you have empowered our audience to better understand their symptoms, recognize early signs, and then more importantly, seek timely medical care, actions that can truly help them out. So do reach out to your doctor and your cardiologist when you're having these symptoms to understand better. So we deeply appreciate your commitment to patient education and your support in raising awareness of atrial fibrillation. Thank you very much for helping us further our mission to fight heart disease and bringing reliable cardiac insights closer to people everywhere. And thank you to everyone who has attended and for being part of today's important conversation. Together, we are building a healthier future. Thank you very much.
Thank you.
Thank you.